Hi everyone. So this is Dr. Kainat Mirza here. So we are going to start with psychiatry. Let me give you a little idea about MCCQE1 before starting of psychiatry. So MCCQE1 is based on two things. Your question means like your multiple choice questions and your CDM questions. So what is multiple choice questions? They will give you some statements. They can be very long, they can be very short, or they can be very to the point, or they can be based on your knowledge, and as well as they can be based on some scenarios, like maybe you have to make some diagnosis, but it doesn't mean that you have to know the basic knowledge. Sometimes they ask you the most appropriate thing. Sometimes they ask you what is the first thing you will do. Sometimes they ask you what is the best choice. So it means in the four choices there will be two or three which will you actually do for that patient, but what they're looking here is what is the most appropriate thing you will do. Like let's suppose if there's a person who is having a trauma, so you can do either fast scan for that person, ultrasound, maybe passing IV lines. But what they are looking here from you is what are you going to do exactly. That person is coming in emergency medicine, like or maybe coming in an OPD, because a lot of people mix up these kind of setting. Like a lot of people keep on missing about what are you going to do. Like maybe you need to do ABC, airway, breathing, and circulation. So you have to know a basic idea about how you're going to get that grip, or how you're going to approach that question. The approach is very important for MCCQE1. So whenever you are going to start, always keep that questions in your mind. How and when and what are you going to do for that patient when you are going to start the evaluation for that particular scenario. Okay, so let's suppose if you are going to start with psychiatry, what you need to know in psychiatry, how you are going to approach that person, because in the particular setting you don't know that this person is coming with you for an actual cause, or this person is having some sort of particular underlying psychiatric condition which he is telling you and you are not sure about what you are going to do. So you are going to start with the screening questions. So what are the screening questions for the major psychiatric disorders? So let's suppose if the patient is coming to you and asking, like, I am having an abdominal pain, but there is no leading cause for that abdominal pain. So what are you going to start with the questions? So you are going to ask that person, have you been feeling down? And you have to know these kind of questions, because in CDM question they directly ask you by writing down a statement how you are going to approach a person who is coming to you, or what are the basic questions. What are you going to ask from that person? Like if a person is looking down and depressed and hopeless, how you're going to approach that person? It means they have already given you the statement of have you been feeling down, depressed, and hopeless. So you're not going to start from the very particular a question by asking about how you're feeling down, because in the statement they have already mentioned that the person is feeling down, depressed, and hopeless. Now your next thing is you are going to ask for the anxious, worry. Has there any been time in your life where you have been feeling? And now when you're going to talk about these things, like screening question, what is the most important screening question in the psychiatric disorder? The most important psychiatric disorder, the main screening question that you cannot miss, please keep that in your mind. What are that question? The question is harming about yourself, but it doesn't end it here. Harming about yourself and harming somebody else as well. It means you cannot write these two lines, like harming yourself and harming somebody else, in one line. Like maybe in a write down CDM question, they're asking you what are the main thing that you will like to screen in this psychiatric disorder, because people keep on asking about, okay, do you see or hear things? That is important as well. But in this case scenario where the person is coming with a psychiatric disorder, what they want you to evaluate as a family physician, because when you are going to refer that person to a psychiatrist, he is going to eventually make sure that this person is having schizophrenia, or she's or like depressive disorder, whatever. They're going to keep on asking question about these things, so they will eventually come up with any of diagnosis. But you as a psychiatric disorder is going to make sorry you as a family physician are going to make sure that this person is not going to harm himself and somebody else. So this is the main important thing as a family physician you are going to approach. Okay, so have you thought of harming yourself or killing yourself? But it doesn't mean that only yourself. You are going to ask, like let's suppose if they have given you two options, then you can write down killing yourself or harming somebody else as well. So these are two different things. Okay, I hope that makes sense for you, because if there are two options then you can write it down, but it doesn't mean that you can write down these two things in one line. Okay, So these history questions are very important on the basis of the history, how you're going to approach a psychiatric disorders person, because in CDM questions they like to find out if you know how to approach that person or not. Okay, so history, how you're going to introduce identifying this data or complaints history, so you are going to particularly read everything. Now, coming to here, psychiatric functional inquiry. I'm giving you an idea about what kind of questions they can ask you so you can have a better idea how you're going to approach these kind of psychiatric questions. Because they don't like to ask you some straightforward things. They just ask you on the basis of, like you are sitting in a particular setup and the person is coming to you, how you're going to approach that person. That setup could be emergency, that setup could be OPD, like that setup could be outpatient department, that setup could be, anywhere. So those kind of things you have to know, that what they are telling you. If you are sitting in a walk-in clinic and somebody is coming to you, if you are working in an emergency as an emergency physician, what are you going to do for that person? Now, psychiatric physician functional inquiry, mood, other multiple disorders, anxiety, psychosis, and safety. So safety is very, very, very important thing. If they ask for one thing that are you going to rule out as a functional inquiry, the safety is the most important thing. Now, past medical history, medications, family medical history, past personal and developmental history, so-called lateral history, obviously about the details required. Now, mental status examination. This is very, very, very important. Don't miss these things, because sometimes they ask you, how are you going to evaluate that person? If like in a geriatric medicine, if the person is coming, how you are going to rule out that person is having delirium or actually dementia or actually some other psychiatric disorder. So this is something as a mini mental status examination. It's very unlikely they ask you about the components of mini mental status examination. Usually they like to ask you if you know about MMSC. MMSE, yes. So if you know about MMSE, but if you don't know, right? Like if they ask you how are you going to evaluate the mental status condition for that delirium, so the thing you are going to round at is mental status examination. The other things that those things for the delirium, those things come after MSE. So you are going to start with this one. It's appearance, behavior, speech, emotions, perception through content, and previous insight and judgment and cognition. So everything will be covered here, then moving on to further particular things over there. So in the appearance you are going to check for that, then speech, then mood and effect, perception for checking for hallucination, illusions. So don't just write down all these things or stop yourself just by reading the definition of hallucination. You need to know the difference between hallucination, illusions, delusions, derealization, depersonalization, because there might be some scenarios where they give you that there is a person who is coming to you and telling you that there is a change in the self-awareness. Usually what happens is, in these kind of people, they don't have perception, so they don't tell these kind of things by themselves. A person is brought by his friend who is telling that this person feels unreal and he is having a self-awareness. What is the diagnosis, or what is this called? So you have to know, is this called depersonalization or derealization? So it's very important you know the definition of these things and how you are going to do the next thing. Let's suppose if they have given you and you already know this is depersonalization, now you're looking for the answer depersonalization, but the thing they are looking for is what are you going to do next for this person. So how are you going to approach the person who is having depersonalization? Okay, so don't just limit yourself by knowing only the definition, how you're going to proceed on from there, because sometimes they just don't ask you what are you going to do that, but they move on to the next thing if you even know how to approach that person. There is a poor correlation between the clinical impression of the suicide risk, for example, like frequency of attempts. Like people who are doing the attempts, it doesn't mean that they actually want to do the suicide. Sometimes they are looking for attention. Okay, so you don't have to mix those things. Then spectrum of the effect, full, restricted, blunted, or flat, like how kind of the person is reflecting to you. Okay, now coming to here, cognitive assessment. Use MMSC to assess, then orientation, memory, assess, and correlation in the language. I have seen one of the question in, I think, ASQ Bank, where they were asking more about, what is MMSC scores. So total score is 30, out of less than 26 is this, then 20 to 26 is mild, and 10 to 19 is moderate, and less than 10 is severe. So in some Q banks, they usually try to ask about these kind of things too. The key to differentiation between obsession and delusion is that obsession are usually ego dystonic and meaning unwanted and not fitting with the person goals and self-image, while delusion is ego-syntonic. Okay, then delusions, it's one of the most important table of the psychiatry. This one, this delusion. What are the further types of delusion? persecutory, because there is so many definitions about these ones which is not written in Toronto notes, but there are some MCQs in UWord, there are some MCQs in MBOS, and there are some MCQs in ASQ Bank as well, where they were further asking about delusions as well. And then obviously in the MCCQE1 practice test, there are some questions about delusions as well. So you need to know all the different types of delusions. What are those? And what are they actually called? So persecutory, where the person is trying to cause harm to you. References, where there is ordinary regular events as having direct reference to you. Then erotomania. Another, in love with you. Then grandiose, where there's having special feelings. Then religious, he is having this higher belief about himself. Then somatic, that you have a physical disorder. Then holistic, that the things do not exist, or sense that everything is not real. Then thought content, so you can read about these things: suicidal ideation, preoccupations, obsession, magical thinking, ideas of reference, overvalued, so those things, insight and judgment, cognition. So make sure you Google some things, more definitions about delusion, go to and write down the topic and types of delusions, and actually do some research about this delusion topic as well. Then assess insight and judgment. What is insight? Insight is somebody, when somebody knows or acknowledge that there is something wrong with him, and he actually wants to get the treatment. Usually people who have personality disorders, they lack insight. They don't know that they are going through some sort of thing. Some people who are living with them, they figure out those things and brought to the hospital to make them, get the medications or whatsoever. But this is not whatever you need to know, as a family physician, because this is something which as a psychiatrist needs to know. Then coming to acknowledgement of the sentences, departure from that baseline. Why it is important here as for you? Because the person who is as an insight is willing to get the treatment. The person who lacks insight is not going to get the treatment. Because what happens is, sometimes there's a person who is coming in an emergency medicine, who is getting suicide attempt, who just did a suicide attempt. Is he willing, when he's going to leave the hospital, is he willing to not do the suicide? How are you going to decide? By checking his insight. Is he ashamed of what he did? Is he feeling bad about if he did a suicide attempt? Does he know what he has done? So these kind of things are going to let you know what are you going to further particularly do about this person. Are you going to keep that person in the hospital, or are you going to discharge that person, or let him go and bring him back on a follow-up? Then judgment, like can be dressed properly, acting, taking care of themselves. That person can tell you that this person is actually having a schizophrenia or not. Then this one here, Menti-Maxwell assessment. So, just all about, you just have to read or memorize these kind of things. Approach to management, usually CBT works for everywhere. There are some ECT, pharmacological, some other motivational behavior therapies, and all of those things. So you can just read more of those things, but usually CBT works for every single thing. Then suicide, except for one. Then suicide. Okay. Now, if we move on to suicide is very, very, very important in psychiatry. Why? Because there is a lot of questions that actually, in the end, in the psychiatry, hits suicide. Because why people want to leave the hospital after suicide? If they want to leave, are they willing to change their life, or are they going to keep on attempting the suicide? Are you going to keep that person in the hospital, or are you going to discharge that person? These kind of questions are usually asked in CDMs. They can be asked in MCQs, but as an if you're as you all guys are already aware of that, MCCQE1 usually ask too many questions from ethics. They actually ask too many questions from psychiatry as well. Why? Because in the ethics, in the end, they are interlinked with each other. Then ask every person, have you had any thoughts of wanting to harm or kill themselves? Then passive ideation, active ideation. I think about killing myself. I would rather not woke up, because this person is not actually thinking or having an active plan. He just feel like if he would have been dead, then it's fine. If he wouldn't have been dead, then it's fine as well. Then assess, plan, intent, past attempts. Why past attempts? Because this person, if he had any past attempt, he might try it again as well. If intoxicated on the first result, then it. And when you are evaluating a person who is having a suicide attempt, always make sure that there is no child involved, there is no other person involved, and there is no geriatric. Okay? Because in the person who is old or somebody like that, is he try to kill that person or something like that? So it's also one of the thing that you need to rule out. Like, you can figure out if the child is involved indirectly. Let's suppose if a woman or a mother of 3 kids, she tried to kill herself, it's totally fine, she is trying to kill herself. But if she trying to kill herself and as well as the kids, then it means you have to involve the child aid society as well, to for because this is a child abuse thing. Childs has their own particular so they are going to involve the child aid society CAS, so they are going to help that person for that for the suicide controlling thing. Then assess suicidal ideation, onset and frequency of the thoughts. When did this started? How often do you thought? Controlled over suicidal ideation. Then intent, intelligibility, assess to means, time and place, provocation, protective factors, final arrangement, and practice suicide or abortive methods. Then ambivalence, and then all of these things you can read. Most of the important things are here. Risk factors. Don't miss out these ones. Risk factors. It's very, very, very important. So serious illness, no spouse, organized plans, suicide in the family, rational thinking, ethanol, previous attempts, depression, age, sex is the male. So previous attempts is not very correlated with the suicide. A person who had done it could be one of the other psychiatric disorder as well for looking for attention. Now you can read all of these risk factors. Now what I want to highlight here is the management. When are you going to keep that person in the hospital and when are you going to discharge? It is very, very, very important, because usually in the CDM question they give you a scenario where the person who's already been mishandled for the suicide, are you going to discharge that person and how you're going to discharge that person. So this is here, form 30 to notify them for the admission, and then you are going to discharge that person. Usually this is for Ontario. So what are you going to do is, if let's suppose usually we we are going to write the exam for whole Canada, so we don't have to go for the things which are actually being practiced in particular provinces. So if the patient refused to be hospitalized, complete form for an involuntary admission and must give patient form 30 form. So it means if you are going to write down the answer, you are going to write down, if the patient refused to be hospitalized, what are you going to do next? So you are going to write complete form of an involuntary admission, because this is going to be done for the whole Canada, but the rest, this 30 form is going to be only done for in Ontario. Maybe there is another form for somebody, some other province, but this form 1 is for all over the Canada. So you are going to particularly write this answer in your CDM if they ask for it, the person doesn't want to be hospitalized, and that person should be in their proper senses and able to make the decision. Then you are going to do this. Okay. Then proper documentation for higher authorities. Hospitalization should be strongly considered. Do not leave patient alone. Remove potentially dangerous objects. So you are going to refuse, are you going to keep that person for the lower risk? What are you going to do? So how are you going to find out if the person is having lower risk or higher risk? That's even more important. Why? Because they are going to give those clues in the scenario and ask you to evaluate if that person is having a higher risk or lower risk. And where that is written, it's written here, the risk. So you can find out if the person is having a previous attempt, eating disorder, or any other particular disorder, psychiatric disorder, that person will be having the higher risk. So you are going to keep that person unless you rule out that this person doesn't have any other psychiatric disorder. Patient with the depression, then you are going to hospitalize and keep on doing the other further things, like management of this depression, management of the alcohol substance disorder, personality, schizophrenia, parasuicide, ideation, behavior. So these are the very, very important things. Please, please, please make sure whenever you are reading any topic, do MCQs of that thing. You will not get a proper idea of what I'm trying to say here, as focus on the thing, focus on the idea of what they are looking for in your questions. And if you get the proper idea what they're actually asking you, you will be able to get the good attempt of that question. Okay. Because if you don't have any idea what they are looking for from you in that particular question, and you are going to let's suppose if they're asking me how I'm going to do the next person, I'm writing down higher risk, this is the higher risk person, and I'm not writing down complete and involuntary admission. My thing is going towards the same direction, but their answer is this thing, but I'm writing something else, right? So it's not even in the same thing. So you have to properly train your brain in a way where you are going to write down the answer what they are looking for. So please keep on practicing a lot of questions. It doesn't matter what kind of question bank you are using. It doesn't matter if you use U-word, because there is a lot of people who actually use U-word and actually cleared this exam. So it doesn't matter, you have to actually particularly buy ACE QBank or whatever QBank you want to use. Okay. I hope this little bit of my video helped you. So do practice a lot of questions. I will stop here. And if you have any question, keep on asking me. I'll definitely love to answer. Please don't miss out these sidebars. These are very, very important. And other than Toronto Notes, I won't recommend using any other book, because once whoever has attempted this QE1, they had, briefly had an idea that most of the questions are coming from Toronto Notes. They have covered a lot of things that is actually important for the exam. Okay, so you won't be misguided or misleaded, or you are not doing proper, or you are not covering everything. So if you do Toronto Notes, you will be satisfied enough when you are standing in front of exam hall, that you have done everything. So you just have to go inside and write down your exam. Okay, so keep on practicing a lot. You don't have to do so many complicated MCQs to get a good grip of things. In the end, the things are the same, and things are very, very easy. Just train your mind how people in Canada, or how doctors in Canada approach you when you go to their OPD setting, or you go to an emergency setting. In the end, they will ask you the same things in the exam. Okay, good luck everyone. If you have any question, please post, and I will definitely love to answer. Anybody who has any question from here? So, I mean, there was a lot of you who have asked questions, which what should I do from Toronto Notes? One of the topics that you should be doing from the Toronto Notes, ethics. It's very, very important. And I feel like the best ethics has been covered in Toronto Notes. Along with that, do CMPA. Now, moving on to anesthesia, there are some topics that you need to do from anesthesia. Don't skip it out. It's very important. Then cardiology, you can do some other resources if you're good in cardiology, but you have to get a basic idea about STMI, NSTMI, unstable angina, those kind of things. So, you need to know. Along with that, stenosis, atrial fibrillation, those are important as well. Clinical pharmacology, you don't need to know that. Dermatology, yes, along with their pictures. Don't do dermatology without pictures. Pictures are like everything. Okay, don't do dermatology without pictures. Even if you are doing the treatment, pictures and dermatology. Then emergency medicine, whole emergency medicine, very important. Endocrinology, there are some topics that you need to do from here, especially diabetes, thyroid. So family medicine, whole family medicine. Gastroenterology, some of the things, very, very, like some topics are very, very important. Then general and thoracic surgery, I would like you to do this from here, because in the end you need to know, like what I said is, like if you are going to do an ultrasound in fast scan in a traumatology patient, like in a trauma patient, because in Canada the approach is kind of different from other countries. So that's why if you do it from Toronto Notes, at least you know how you're going to approach that person without mixing up those things. If you do from MTB or those things, yes, you can do cardiology or those things, but in the end, please follow Canadian guidelines, especially when you're doing an anti-hypertensive drugs, or if you're going to approach a person of diabetic, those kind of things. Okay, then geriatric medicine, MCCQ one favorite, geriatric medicine. Gynecology, yes, I did gynecology from here, the whole topic. Hematology, skip it from here, it's too much here. Infectious disease, some of the topics, not all. Rabies, those things, not all of them. Medical genetics, it's important, because I feel like there are some questions in this few of the 13 pages that is actually being touched in my exam. So it's very important. Then medical imaging, this is more of ultrasound, so you can just skip it up. Nephrology, some topics, not all. Neurology, some topics. What are those some topics? You have to find out from MCCQ objectives. Neurosurgery, some of the topics. Obstetrics, whole. Ophthalmology, I would say do some tables and you are good. Orthopedics, it's very exam favorite. Or otolaryngology, like ENT, some tables. Pediatrics, exam favorite. Palliative medicine, no, you can skip it out, it doesn't matter. Plastic surgery, some of the topics like tetanus, it's actually written very nicely in plastic surgery and you have to do it. Psychiatry, exam favorite. Public health and preventive medicine, don't do it from anywhere, and you don't have to do public medicine, public health, all of it. Just do some of that, because in the start, like, writing about the public health in Canada legislation, you don't need to know every single thing about that. Okay. Along with that, you don't need to do end of those appendix and reportable disease. Yes, reportable disease is very important. Just do that on your fingertips. Respirology, just do some topics. Same goes for rheumatology and same goes for urology. Okay. So somebody, can you please share this video recording? Yeah, I'll definitely do that. If you have any other question, you can ask me right now, and I'll definitely conduct more sessions. I'll just busy with some stuff, and yeah. Anything else? Are we good here? No questions? Okay, so please do psychiatry, whatever I had done up till suicide. And please, whenever you study any topic, please do some MCQs, because some MCQs are not just going to help you with MCQs, but also with the CDMs. Okay, so do CDMs as well. I mean, you can practice CDMs with some other person, or you can practice MCQs, CDMs with yourself as well. In the next video, I'll definitely tell you how I prepare my CDMs. You can actually do that as well. Follow the same whatever option. Okay. So until then, we will see you next time again. Everybody have a good day.